Hello, everyone, and welcome to today's webinar. Before we get started, let's be sure that everyone can select their language channel. The options available for this session are English, Spanish, or original audio if you would like to hear the audio without interpretation. For people connecting through a computer, you can choose your language channel by clicking on the interpretation icon to the bottom left that looks like a globe. For people connecting with a mobile device, you can choose your language channel by selecting the More option, then Interpretation, then selecting your language from the available options. We extend much gratitude to our interpreters today. We also have live captioning available that can be accessed by clicking on the multimedia viewer box on the right of your screen. I would now like to welcome you to our webinar. Today's webinar is Survivor-Driven Advocacy at the intersection of partner-inflicted brain injury and mental health. My name is Victoria Wanku. I also go by Tori, and I use she, her pronouns. I am a citizen and member of the Spokane tribe with tribal affiliations with the Coeur d'Alene and Caldwell tribes as well. I am also the Training and Technical Assistance Manager with the National Center on Domestic Violence, Trauma, and Mental Health. Now for some troubleshooting tips about this platform. If you get disconnected from today's session at any point, please re-enter the session using the original webinar link that was emailed to you. If the sound is unclear, it is likely due to an unstable internet connection. And if this happens to you, feel free to call in for a better audio connection. If you are experiencing technical difficulties, you can directly chat with Carla Alegria, who is also with the Center for Assistance. If you are unable to contact Carla, please reach out to WebEx Tech Support. Carla will post that phone number in the chat. We welcome you to use the chat feature to share thoughts, questions, and resources throughout the session. Your screen may look a little different depending on what kind of device you are using, and usually the chat box can be found at the bottom right of the screen. You may have to click on the chat icon that looks like a speech bubble to open it. Let's test the chat feature now, so please introduce yourselves in the chat and let us know where you're joining us from today. The National Center on Domestic Violence, Trauma, and Mental Health is a special issue resource center that promotes an accessible, culturally responsive, trauma-informed approach in the domestic violence field and an accessible domestic violence, culturally responsive approach in the mental health, substance use, child welfare, and legal fields. We offer training and technical assistance, research and evaluation, and we also participate in policy development and public awareness activities. Our center is headquartered in Chicago, where I'm also residing, which is on the unceded homelands of the Council of the Three Fires, the Odawa, Ojibwe, and Potawatomi nations. These traditional stewards, along with other possible inhabitants, have lived and thrived for thousands of years. Today, the Council of Three Fires continue their practices, cultural traditions, and speak their languages. I invite each person to learn about the land you're connected to And one resources to do that is to use the website native-land.ca. As part of our commitment to caring for each other, I want to encourage you to take care of yourself throughout this session. We will discuss domestic violence, intimate partner violence, partner-inflicted brain injury, and mental health. This is a space that centers on strengths, lived experiences, healing, and well-being. If at any point you need to take a break, we encourage you to take care of yourself and return when you are ready. Today's session is a focus on specifically the intersections of partner-inflicted brain injury and mental health. I also wanted to share that we do have a new infographic that is available on our website. It's the intersections of domestic violence, mental health, substance use, and partner-inflicted brain injury. This was done in collaboration with our partners at the Ohio Domestic Violence Network, Rachel Ramirez and Cheryl Stahl. There will be a complimentary fact sheet coming later this year expanding on the infographic information. And when you are able to access today's slides, you're more than welcome to go to this slide and click and hover directly on the title for this infographic to access the website link. Now to start with today's session, looking at partner-inflicted brain injury and domestic violence. Partner-inflicted brain injury is often an overlooked experience for many survivors of domestic violence. For advocates, our initial response is to be supportive and empathetic to the traumatic event or events that survivors have endured by providing space that fosters physical and emotional safety and connection. It is not our lack of empathy that causes us to overlook the impacts of partner-inflicted brain injury. It is the lack of language and nuance we have to describe what partner-inflicted brain injury is and the impact it has on a survivor's mental health. So what is brain injury? In order to remain survivor-driven and survivor-centered, it's important that we understand what a brain injury is and how it may show up in domestic violence situations. By definition, a brain injury is damage to one's brain by an external force to the skull or a lack of oxygen to the brain. So we have traumatic brain injury, which is an external force to the skull that can include, but not limited to, punching, kicking, or objects or blunt force to the head. In the context of physical abuse, strangulation is a form of oxygen depletion to the brain because force is applied to the throat, causing the closure of airway and blood vessels. This is considered an acquired brain injury because it can cause long-term consequences, impacting the physical function of an individual. What is partner-inflicted brain injury? Partner-inflicted brain injury is a brain injury that is caused specifically by an intimate partner by either external force or strangulation. Partner-inflicted brain injury can happen repeatedly when physical abuse is present. This can mean repeated hits to the head, being thrown against hard surfaces, pushed down a flight of stairs, and ultimately is a purposeful targeting of vulnerable areas of the body that do include the head, face, and throat. With the stigmatization of domestic violence, survivors may be hesitant to reveal the full extent of the abuse they have experienced due to shame, guilt, or self-blame, especially since this abuse is happening by someone they love or intimate with, or ultimately someone that they know very well. And it can often occur in private settings with no witnesses in sight, which can cause a survivor to feel like they won't be believed or feel too ashamed to share their experiences. Another reason or additional reasons why this can be overlooked by domestic violence services is because even if a survivor does receive medical care The diagnosis of a brain injury may not happen because there is a lack of information or evidence present in an MRI or CT scan. Therefore, this can influence survivors to minimize any potential head injuries and be overlooked if they're not directly asked about these experiences. So, impacts of partner-inflicted brain injury. Women often differ in incidence and with symptoms based on research from the Concussion Alliance of 2024. Female traumatic brain injury patients between the ages of 0 to 18 years old were 3.2 times more likely to develop a hormonal disorder impacting physical and cognitive growth. Women were also presented with significantly more initial symptoms than men, and were also more prone to developing post-concussion symptoms following an injury, which means concussion symptoms that last longer than normal. So this can include headaches, fatigue, coordination challenges, light sensitivity, trouble concentrating, and mood swings. For recovery, symptoms were significantly reduced when women were prescribed a light aerobic exercise routine instead of prolonged rest that were often prescribed to men. This demonstrates the need to further explore how brain injuries impact women, especially when it is involved with partner-inflicted brain injury. For short-term impacts, specifically for the physical and emotional, a survivor may not have the ability to care for themselves for a time period because of the impacts the head injury can cause for day-to-day living. So this can be concerning, especially if the person they are relying on to care for them is an abusive partner who can leverage this time period to further isolate the survivor from additional supports. For long-term physical and emotional, a survivor can experience multiple or chronic brain injuries from an abusive partner that can take place over months or even years. As mentioned before, this is because abusive partners are aware and are intentional about causing harm in areas that are highly vulnerable to injuries such as the head, face, and throat. This can cause survivors to have difficulty regulating emotions because of the impact it has on the cognitive and nervous systems, and it can also impact day-to-day living if the survivor experiences more headaches, nausea, or coordination challenges. For long-term relational and social impacts, this again can cause high levels of isolation from friends, family, and services if the abusive partner doesn't allow the survivor access. Survivors who have experienced partner-inflicted brain injury may also be impacted financially. This may be due to the inability to physically attend work due to the injury sustained or having difficulty staying on task at work because of change of vision, headaches, or forgetting to do certain things. This lack of accessibility and support in the workplace can further isolate survivors from remaining financially stable and potentially being stigmatized as lazy or incompetent within these settings. For statistics of partner-inflicted brain injury, in a survey of 49 survivors that was done by Nemeth et al. 2019, it was a survey that was done with survivors accessing domestic violence services who reported that 83% were strangled and 86% experienced at least one assault to the head, and 49% were hit in the head too many times to count. So while this is a small sample size, it can highlight and demonstrate the significance of partner-inflicted brain injuries amongst survivors. And with these statistics continued, it was also found in the research done by Montgomery and Ramirez 2021 that a survivor is 7 times more likely to be killed by their partner if strangled and more likely to struggle with PTSD due to strangulation. Now, we're going to shift from partner-inflicted brain injury and domestic violence to mental health and domestic violence. This section may feel like a little bit of review if you've watched the previous webinars for this series, but it is important to review again so that we can see the direct link between partner-inflicted brain injuries and mental health experiences among survivors. So numerous studies have shown that victimization by an intimate partner increases a person's risk of experiencing mental health challenges. Those affected are 3 times more likely to have post-traumatic stress disorder, major depressive disorder, or self-injury. Those affected are also 4 times more likely to have suicide attempts and 6 times more likely to have a substance use disorder. Depression, PTSD, and substance use are also associated with an elevated risk of suicide. With these experiences of mental health effects, they can be weaponized by abusive partners to continue exerting power and control over survivors. And this is referred to as mental health coercion. And according to this survey that was done in collaboration with the National Center on Domestic Violence, Trauma, and Mental Health and the National Domestic Violence Hotline, mental health coercion is actually a very common experience. Within the survey, there is about 2,500 callers, and it was found that 89% had experienced at least one type of mental health coercion that included 4 and 5 said their partner accused them of being crazy. 3 and 4 said their partner deliberately did things to make them feel like they were losing their mind. 1 and 2 said their partner threatened to report they were crazy to keep them from getting things they wanted or needed, such as protection orders or child custody. And 1 and 2 sought help due to feeling depressed or upset. Of these, half said their partner tried to prevent or discourage them from getting help or taking prescribed medications. With mental health coercion, the tactics are designed to use mental health and stigma to exert power and control over survivor, which can include undermining the mental health and emotional stability of a survivor, which can then be exploited by an abusive partner to have personal or financial gain in regards to the survivor's mental health. This can also jeopardize the parent-child attachment and discredit survivors with potential sources of safety and support. And it's often common to use mental health experiences or challenges to justify the abuse. So therefore, overall, these tactics impact the survivor's ability to access mental health supports, whether that is through friends, family, or additional services. To help contextualize the impacts of mental health coercion, I wanted to share a couple quotes from the survey that came with the 2,500 callers. So the first quote states, "He'd tell me I shouldn't get any help or take medications because he didn't want anyone to know about my depression. He'd say things really softly under his breath. And when I'd ask what he had said, he'd tell me I'm crazy and that he didn't say anything." And the second quote states, "He told me that if I tried to leave, he was going to take the kids and I would be in a psych ward." Now that we have an understanding of the intersections of partner-inflicted brain injury and domestic violence, and then mental health and domestic violence, We will now look at the intersection of partner-inflicted brain injury and mental health and how this can further exacerbate experiences for survivors accessing our services. For mental health, whether these are diagnosed or potentially something the survivor feels like they may experience, this can include anxiety, depression, PTSD, and many other types of mental health that could be bipolar disorder or even eating disorders. For partner-inflicted brain injury, some of these experiences include having headaches, nausea, blurry vision, and ringing in ears. For overlapping experiences with mental health and partner-inflicted brain injury, sometimes brain injury and mental health share similarities in how symptoms can present themselves. For instance, difficulty remembering events, difficulty focusing, trouble sleeping, challenges with managing mood, and the stigma. Because brain injury may not show any obvious signs or symptoms, experiences of brain injury can appear to be related to something else. It's easy for staff and advocates to miss these experiences or be dismissive and be angry or frustrated with people later. So, for example, I want to take the experience of difficulty remembering events. And so, as I reflect on my own experiences as an advocate, it was common for the survivors or the individuals that I engaged with to miss appointments, forget things that needed to be submitted for other social services, or express that they couldn't remember much of what happened when recalling the events or the events of abuse. What I want us to keep in mind as advocates and staff is that these overlapping experiences of mental health and partner-inflicted brain injury is that we're not always going to know what's happening underneath every time. With the impact of trauma, the intersection of mental health and partner-inflicted brain injury can further stigmatize the experiences that survivors have by being labeled lazy, incompetent, or ungrateful for the support that we provide. In reality, it is us, the advocates and staff, who do need to be comfortable of not always understanding, especially if there are overlapping experiences of mental health and brain injury. Remember, it is the survivor who is giving us that permission to see parts of their journey to healing, and that should be regarded as an honor to us. And so with these overlapping experiences, it is also important for us to understand how abusive partners can leverage this to further exert power and control over a survivor. And so with the overlapping experiences of mental health coercion and partner-inflicted brain injury, the first one that I want us to look at is the manipulation of treatment. And this is the attempt to influence diagnosis or treatment, whether it is for mental health challenges or for partner-inflicted brain injuries. There's also the threats to having a partner committed due to the partner-inflicted brain injury potentially being viewed as mental health symptoms, as we had seen in the prior slide of difficulty being able to remember, being able to focus, or just having mood swings in general. And there's also the withholding of resources needed to access care, whether this is to access health care for the brain injury or mental health services that could potentially be helpful for the survivor too. Another way that mental health coercion and partner-inflicted brain injury intersect is through the control of medication. And so this can be preventing medication adherence, whether that is the abusive partner not allowing the survivor to take pain medication for the injuries they have sustained. And this could also be not allowing them to take the medication that could be for mental health challenges or experiences with, such as depression or anxiety. This can also include forcing the survivor to take medication and or over-medicate, which is dangerous in regards to SSRIs, which is what you use for depression and for anxiety. And also if they're taking any pain medication that could potentially cause more harm than actual good, such as allowing them to force more, which can then have them become addicted to this medication. There's also the potential for stealing the medication that the survivor is using. And the abusive partner can also insult the survivor for taking prescribed medication by gaslighting them or minimizing their experience, and also by calling them an addict or calling them crazy for needing this type of support. And the last mental health coercion and partner-inflicted overlap that I'll share is the threats of child welfare involvement, threats to child custody, and allegations that mental health or partner-inflicted brain injury symptoms make someone unable to safely parent, when in reality that is not true. We ultimately strive to create the bond between the child and the non-abusive parent. So I want to stop here for a moment and have us reflect in the chat again by answering this question of, what are we doing well to support survivors experiencing mental health challenges or partner-inflicted brain injuries? So again, what are we doing well to support survivors experiencing mental health challenges or partner-inflicted brain injuries? And I see some responses in the chat of allowing for easy rescheduling of missed appointments, that there are also good therapists who can help in providing trauma-informed care too. Yeah, and also normalizing talking about both mental health and brain injuries, which is also very much needed, especially since, again, these are overlapping experiences. And I do see in the chat that it has been shared that ODVN has tools on their website that address how to talk about brain injury and accommodations for advocates, which is a great tool. I do believe we're actually sharing some of that information later on in this slide deck. Others have noted that they talk to every client who comes to shelter about getting medical and/or mental health services as needed and supporting them in access mental health care. Yeah. So again, thank you all for sharing those responses and how you're already striving to meet these needs with survivors accessing your services. I want us to continue forward and think about the ways of how we can help. And this format right here comes from the infographic that was again done in collaboration with the center and ODVN. And so what advocates and providers can do is think about these steps of being aware, being curious, being accessible, and being empowering. So being aware and checking in on ourselves first is a great way to foster connection and rapport with survivors. So asking ourselves, do I have what I need to respond? What helps me stay grounded? And how am I feeling? And how might that affect someone else? Another way we can check in with ourselves is questioning our own biases and assumptions when we witness a survivor experiencing forgetfulness, mood swings, or trouble focusing or sleeping? Do we feel ourselves make distance between us and the person accessing services? Do we assume that they're not motivated, organized, or capable for caring for themselves? When checking in with ourselves first, we need to make sure that we are also considering the ways we convey empathy and foster connection and sense of belonging for the survivors accessing our services. To be curious, this can happen at the initial engagement, and you can talk with each person at intake about how shelter living can be challenging. And one way that this can be done is through an intake form that many domestic and sexual violence organizations introduce at the initial engagement. And so for Be Curious, this comes from the CARE framework, where we can have potential questions within the intake forms that ask about brain injury experiences. And so these questions can include, have you experienced physical harm to your head or strangulation? When did you experience this harm? And did you want to receive medical attention? Or did you already receive medical attention? So to have a more comprehensive review of the types of questions you can ask, you can also access the chats worksheet that was created by the Ohio Domestic Violence Network. It's a handout that you can include at intake or adapt the questions to fit what you already may have for this intake process. And again, once you have access to the slide deck, you can go to the slide and click directly on the chats worksheet that'll lead you directly to the website. So this emotional support plan is also something we've discussed in previous sessions for this series. And it is most certainly applicable to brain injuries, especially since we see how overlapping experiences of mental health and brain injuries can have common experiences and symptoms. So for instance, Montgomery and Ramirez 2021 have noted that psychological trauma impacts brain function and stress response systems. Brain injury is connected to these issues. So with the overlapping experiences of mental health and partner-inflicted brain injury, the emotional support plan can be further adapted to include statements that further explore strategies to feel better, which is the second part of this emotional support guide, as you can see in the purple that says strategies for feeling better. And so you can include statements that say, ways that I can help myself or others help me remember appointments, meetings, or other important things that they'd like to remember. Things I can do if I'm having difficulty sleeping, and things I can do to help with focusing. And this can be related to task, to just simply talking to someone, or just even watching TV, anything that they feel is important or necessary for them to stay focused on. So from the chats worksheet and the emotional support plan, we can also include offering informational materials, which is under the Be Empowering section. And so having ready brochures and resources for brain injuries, domestic violence, and mental health experiences, it is important that we ask for consent beforehand if survivors or individual accessing these services want these materials. I do want to note that if someone says no to receiving information, keep in mind that no can mean not now. So offer info again later on and try offering it in different formats or forms, because people may have no idea that they have a brain injury. And so other ways that this can be offered in different forms or formats is through having informational posters of the impacts of brain injuries, mental health coercion, and domestic violence, offering ongoing education and professional development to staff to stay up to date. And I just want to emphasize, do not diagnose, be judgmental, or demand to know medical history or mental health experiences. You don't need to know any of that to provide support to survivors who are coming to us with help or needing additional resources. So, being accessible and considering our environments comes from the National Center on Domestic Violence, Trauma, and Mental Health in terms of um, our framework of the accessible, culturally responsive, trauma informed framework. And so, to be accessible and inclusive, it's important to offer support with reading materials so that by ensuring that reading materials are concise and have plain language, you can also provide options on the font sizes and text, especially if a survivor is having difficulty with vision. If a survivor is having difficulty concentrating on the reading materials, offer support by reading the materials for them, or ask if there is someone they would like to help assist them. This is important because they may not want to respond to certain questions in front of some people and may only feel comfortable with others. For attending to the potential sources of trauma reminders, for brain injuries, trauma reminders can be far and wide, especially if they have experienced a partner-inflicted brain injury. And such trauma reminders can include certain smells or sounds. In the context of partner-inflicted brain injuries, I want us to remember that a brain injury can make it difficult to regulate emotions. So when a trauma reminder is activated, the survivor can experience a symptom of post-traumatic stress disorder or PTSD, making it difficult to process the emotions and feelings that come with it. Therefore, to be accessible and inclusive, we need to ensure that we are consistently being survivor-led and driven so that we can continue to meet the needs of each survivor with empathy and understanding. So when someone shares they have a mental health and/or partner-inflicted brain injury diagnosis, of course you can listen and communicate with non-judgment and even ask them, like, what does it mean to them? What does it mean that they have experienced this? And how do they view these diagnoses? Also, being aware that, again, people use violence to undermine their partners if there is a diagnosis or even when there isn't a diagnosis. And that systemic misdiagnosis and overdiagnosing does occur, particularly for people of color. So, suggestions of treatment may not always be viewed positively. And when advocating with providers and systems when necessary, advocates can support survivors interacting and navigating the healthcare system. This can come in many forms where an advocate can support a survivor's decision to share that there may be a potential brain injury, especially if they're discussing medication options, attending eye doctor appointments where they have to flash light in the eyes, and that could really be uncomfortable for someone who has sustained a head injury, or even giving information for doctor checkups, for general checkups too. So I want to pause again and in the chat, have us respond to this question for us to think about and reflect with each other. What would help us do better to support survivors experiencing mental health challenges or partner-inflicted brain injuries? I see someone state that I feel like we generally underestimate how impactful it can be to speak slowly with deliberate breaks between words. Yeah, taking breaks when sharing info. Yeah. Sharing a lot of information at once can feel very overwhelming, especially if it's difficult to focus. And then thinking about easier access to support services in rural areas and offering to read things out loud. And the last one that I'll read is to have adequate time to dedicate to working with these survivors rather than being rushed or distracted. Yeah. No, this is great. Thank you everyone for sharing. I'm really glad that we're able to look at the different ways that we can take what we're already doing and then put in steps to improve the practices we already have. So, how can organizations prepare? Organizations can have clear policies that staff can access and implement that focus on mental health coercion, mental health challenges, and partner-inflicted brain injury. A couple of examples that can be implemented include having the CHATS worksheet, an emotional support guide provided to not only to survivors accessing the services, but also to the staff and advocates. This is to help ensure that everyone has the same information and has the same opportunity to identify what helps themselves and others when emotional distress or experiences of partner-inflicted brain injury occur. The worksheet and guide can be placed into each person's own file for access. Of course, confidentiality is important, especially for survivors who are sharing personal practices or thoughts. And so, in order to maintain that confidentiality, I would suggest identifying at least one person that a survivor or staff person trusts to access these files when the need arises. And if no one is identified to access a survivor's worksheet and guide, I really want us to respect this option and continue building rapport that fosters connection and a sense of belonging with these individuals. Another type of policy that can be implemented is when someone is actually experiencing emotional distress that could be due again to the overlapping experiences of mental health and partner-inflicted brain injury. It's important that we allow one staff person to lead and offer options to the person that feel doable in that moment. And this can be done with the guidance of the guide, or if the survivor hasn't allowed anyone permission to review it. It can also be done by simply listening to what the survivor is feeling and what they may want or need in that moment. So overall, it is important to also ensure that the policies implemented are survivor-led and driven rather than fear-based. A fear-based approach can replicate power and control dynamics that the survivor experienced in their relationship to now experiencing it at an organizational level. How organizations can support? Organizations can support the implementation of policies that are survivor-led in a couple of ways. So one way is having ongoing staff training of the intersections of mental health coercion and partner-inflicted brain injury, which can help us stay up to date on the research and data surrounding these topics. It can also allow us to utilize trainings, such as this one, to continue building capacity within our organizations to respond to the needs of survivors who have these overlapping experiences of mental health and partner-inflicted brain injuries. These ongoing staff trainings can also help us confront our own biases when working with survivors who may experience these intersections. And that's because we cannot always assume what is happening. We can always provide support through empathy and allowing survivors to identify ways to care for themselves, because ultimately they are the experts of their lives. Additionally, we can apply community care practices that can be done through reflective supervision and the integration of feedback. And so, through reflective supervision or group debriefings, this can take place after an event has happened. It's an opportunity to reflect on what happened, what was effective, and what we would change for next time. For the context of mental health and partner-inflicted brain injury, it can help us consider how to meet the individual needs and how we can continuously respond effectively to survivors with the overlapping experiences. Again, it is possible that a survivor may not know that they are experiencing partner-inflicted brain injuries, or the challenges of that. So it is important through these supervisions and group debriefings that we discuss how to continue to provide support even when we don't know everything too. For feedback from staff and survivors, feedback can be given through exit surveys for survivors, and it can also be given by staff, whether that's like done quarterly or at like meetings. And so with this feedback, it's important to take it, review it, and implement it to ensure that survivors are continuously informing the services and that we understand how to effectively support survivors at these overlapping experiences of mental health and partner-inflicted brain injuries. And the last way an organization can support is through the development of community partnerships. It's important that we use partnerships that we trust and have relationship building efforts with having cross trainings between organizations and programs to look at the intersections and impacts of mental health, domestic violence, and partner-inflicted brain injury. By having cross trainings, services will no longer be siloed and can much more effectively meet the needs of survivors, especially when we have an understanding of how physical abuse, particularly to the head, face, and throat, can also impact mental health and emotional well-being. Building partnerships specifically within the healthcare system is also beneficial because it can help advocates understand the protocols, especially if there are concerns for physical health. This will strengthen support for survivors accessing these services because it'll help inform when first responders can be called on. By being transparent about the types of partnerships and policies you have, it will allow the survivor to make decisions on how and when they want to share their experiences of mental health and partner-inflicted brain injury. Here are the key takeaways for today's session. The first is understand the overlapping experiences of partner-inflicted brain injury and mental health in the context of domestic violence. Identify strategies that advocates can use to help support survivors at these intersections, and explore implementation strategies to support advocates and survivors at the organizational level. So thank you, and I now open it up to any questions or comments. No, I'm so glad you enjoyed this webinar. Thank you. So there's a question that asks, have there been any efforts to further understand the impacts of traumatic brain injuries on other parts of the body? So from my understanding, there have been efforts to further understand the impacts of TBI specifically on women. In terms of how it impacts other parts of the body, I'm sure that there are other research, how it can demonstrate through like a more scientific lens, how we are impacted through like the nervous system or like emotional regulation within the brain. In terms of relaying that information here in today's session, I unfortunately don't have that information. And yes, this will be recorded and you should be able to receive it or access it on our website within the next week or so. And the slides will be shared with it. Unfortunately, I do not have any suggested readings on polyvagal theory. I see that Rachel is helping with some of these questions, and that she stated that I always say that the brain has everything to do with our body, so brain injury can have wide-ranging impacts on our health. And Lisette, there should be a certificate that will be emailed to you at the end after you have filled out the evaluation. Yeah, and I see that there's suggestions on more polyvagal theory. And I am going to now transition into sharing some of the additional resources that we have for you all to review. So here's my contact information. Again, you will be receiving this slide deck, so if you want to ask additional questions, you're more than welcome to email me or reach out to me through my phone number. I did want to emphasize again and reshare that we do have this new infographic that was done in collaboration with Ohio Domestic Violence Network, and that we will be having a fact sheet coming soon that expands on that information. Here is Tools for Transformation, Becoming Accessible, Culturally Responsive, Trauma-Informed Organizations, which is an organizational reflection toolkit that comes with 2 different guides. We also have the guide for emotional support that's available in English, Spanish, and French. And then we also have Survivor Health Connections, which is increasing access to desired resources. So it's a web page with materials that's designed to increase survivors' access to resources that support their safety and well-being. We also have a training series that looks more at emotional distress and crisis that's in response to mental health experiences. And so 5 webinars with supporting materials on mind-body practices and trauma-informed crisis support. We also have a tip sheet that looks at supervision reflection or reflective supervision, and with a webinar that's changed leadership and supervision using reflection to support both staff and sustainable change. And then an additional resource that comes from the Ohio Domestic Violence Network is their Partner-inflicted brain injury, promising practices for domestic violence programs, which highlights their care framework, and as well as their CHATS advocate guide. You can also visit our website, which is ncdvtmh.org, sign up for our newsletter, and follow us on any of our social media handles here. And our resources, references. So again, thank you all for coming to today's session. Carla, are you able to put in the evaluation link? Awesome. Thank you, Carla. It's shared in the chat now and will also be shared with the follow-up email. Bye, everyone.